My name is Dr. Kent Rinehart. I'm an upper extremity surgeon at Tennessee Orthopedic Alliance, East Tennessee. And I see patients at Fort Sanders and Sevierville. And now just recently this week, I'm going out to Alcoa and helping take care of the Blount County community. And very excited about that venture for us. Really excited about podcast tonight. I have my hand therapist with me, Landon. I think we're just going to talk about basic hand problems, things we see, treat, things we get excited about treating, maybe things that are a little bit more challenging.
Absolutely.
And I think we have some questions for each other and maybe questions that maybe the general community has about what's a hand surgeon, what's a hand therapist, and then we can kind of talk about how we collaborate to help take care of people.
Absolutely.
Do you want to quickly introduce yourself?
Yeah.
And then my thought is, Landon is, and I see people a lot, like, hey, you're a couple weeks after a distal radius fracture or a finger fracture, and you're going to go see my guy, Landon, and he's going to help you out. Like, I think their idea of like this hand therapist is this person who like hides in the closet and has this like putty machine and like you're going to massage their hand for an hour.
Yeah.
So why don't you talk about just your background, what it takes to be a hand therapist, and just kind of that global view.
Yeah, absolutely. So, my name's Landon. I am an occupational therapist who specializes in hands. So I did 2.5 years in grad school at Milligan University. And then before that, I did inpatient rehab and home health. And so orthopedic world is somewhat new to me, but, so hand therapy, a lot of people ask me, what is that? Do you just hold hands all day?
Mm-hmm.
And it's much more than that. So that's a part of it. But a majority of what I do is just focus on the hand. It's specialized from shoulder down to fingertips. And so what we kind of focus on is, hey, somebody's had an injury that's significantly impacted their life in some way, or, it's really caused a lot of inconveniences. And so coming into that, I'm having people with just a range of different emotions and kind of things that are going on. And so my focus is really just to help kind of calm those nerves, first off. And then two, it's really addressing, the things that have been impacted. Mm-hmm. So for instance, like your wrist fractures, your finger injuries, that kind of stuff, education is a huge part. So I'm educating and then also just treating those things in a lot of different ways. So,
my thought of this is, and it's kind of in my practice too, is I'm not only a surgeon, you're not only a therapist, but you're kind of like a teacher, a coach.
Yeah.
Some days I would hate to admit it, but sometimes I'm like a psychologist.
Yeah.
You kind of have all those ventures, but that's some days, some patients you just need that.
They need it, yeah.
So, briefly, how did you kind of wind up at TOA? Like, how did you kind of find that niche to say, hey, I like hand therapy, I like dealing with these types of problems, and then how you kind of drifted to us?
Yeah. Initially, I was working in inpatient rehab, so a lot of those individuals, you would see CVAs, strokes, TBIs, that kind of thing, and a lot of times those individuals might have just significant impairments to their upper extremities. So, for instance, like a right-sided stroke, their left side would be affected. Mm-hmm. And so sometimes their arms would be completely flaccid. Sometimes they would have a little bit of like spasticity to it. And so just throughout that time, working with those specific individuals and just the different things that were going on with them, mostly it was just dealing with the hand and the shoulder, elbow, all of that, and really trying to just get them to use it. And so occupational therapy, we're really focused on just kind of those activities of daily living. So brushing your teeth, using the bathroom, being able to just take care of yourself, or some people are caregivers, so taking care of their loved ones. So my biggest focus was, hey, let's get this thing working. We've got this small window of time to do that. And so just throughout that time, I realized that you can be super creative with just those different diagnoses and things like that. And so, working with that, and then too, just realizing that the hand is just so involved. There's so many things that play into it, nerves, tendons, all of that, joints. And so there's a lot that you can do. And it's really, it's really just an art and a craft. So you can go as deep as you want into that. And so for hand therapy too, you have to have about 2 years of experience before you can take your boards. Mm-hmm. So you're seeing a lot of stuff and it's very involved. And so a big part of that for me was, hey, I kind of want to hone in on this craft and be able to, just get deeper into it and learn more about it and how I can just be the best with it. So
sure. Yeah. I mean, I think that's great. I mean, that's my attraction to hand too. It's just, it's so intricate. And I think every single patient kind of has different specific needs, and you can even tailor it to where on the hand the ailment is. If you have thumb arthritis, you have carpal tunnel, you have a finger sprain. And I kind of like that variability. Every single patient has a different pathology, different problem. And I think the nice thing about me and you down here is at Fort Sanders is we can kind of collaborate to kind of get them back to where they want to be.
Yes.
And every patient needs to be at a different level. They have different expectations, wants, needs, concerns. And that's just what attracts me to kind of the upper extremity, really.
Absolutely.
As far as things that you see and treat, what are some of those things that comes in your clinic first day you're seeing, and hey, it's a Rinehart referral. He's done surgery to him however long ago. What are some things you get, excited about? And then what are like some of those like more challenging pathologies, things that you see? And then how do you kind of like work through that?
Yeah. So common ones that I feel like I've seen recently from you and just in general that we see is distal radius fractures, your CMC arthroplasties, ORIF of the finger, so just a plate that's been put in the finger. And then occasionally, we'll get those tendon injuries, and that's a little few and far between. But so for someone who's coming in, say it's a distal radius fracture, the biggest thing that I'm seeing is, someone might come in with a little bit of swelling. Their scar is still healing up. They're unable to really move. There's a lot of guarding with it. So just from that pain that they might be experiencing, there's a little bit of guarding. And so looking at that, I'm kind of getting just that comprehensive look at what is going on with this person, what are they experiencing from this? And then two, it's just getting a background and kind of just getting that holistic perspective. So, hey, are you a caregiver for somebody? Are you still working a job? If so, what kind of job is that and what's required of your hands for it? And so, looking at those things, and then two, it's just getting them started with motion. That's been a really awesome thing I've seen with your patients too. And having that ORIF, the plate is just immediately getting them started, getting them active. And I mean, the results of that have been so good too. And I think from the other side of that, seeing somebody come in that first time to then discharging them and they're back to picking up their grandkids, or they're back to just doing their job that is their livelihood, that kind of stuff. Ultimately, that's one of the best parts of my job, is getting people back to doing that stuff. So distal radius fractures, those CMC arthroplasties, so that thumb arthritis that's in there, very common. And I think I've heard you say this too. The thumb is roughly 40 to 60% of the hand. So
that's what work comp tells me. So I have to believe that's true.
Yes. Right. So, so that's a big one too. And so what I kind of look at that too, again, is kind of that swelling management, scar tissue massage, working on general movement, working on the thumb, the wrist, that kind of stuff, just really making sure that, we're getting them active and going. And also a part of that too sometimes is just making splints for people as well. We make custom splints like in the clinic, and you send me a lot of those, which is very helpful. And it's good to be able to meet that person beforehand and just discuss with them, kind of the treatment plan that's going to be around too. So yeah, those are kind of some common ones that I see, and those too, I see so many of those. And so those are the ones that I feel pretty comfortable with and pretty confident in. And then the ones that are really challenging can be those tendon injuries. And, depending on what happened to the tendon and how they injured it, there's so much variation to that. And so, and based on like the core strains too and how it was operated on, says a lot too. And so really for those, they're challenging, but also they're coming on the other side of that. It's really awesome to see the progress and basically just the technological advances that have come along with that. The fact that you're able to go in and operate on a tendon is pretty impressive and amazing. And to see the outcomes of that, and to see people actually be able to grip a coffee cup again, or actually use their hand, it's pretty awesome to see that. So challenging, but interesting to see as well. Yeah.
Agreed. Yeah. And I agree with everything you have to say. And I think the nice thing about being down here is you and I have a very similar kind of ideology on patient care.
Yeah.
And in the beginning of practice, I was very nervous about getting some of these injuries and some of these post-surgical patients moving. I wanted to kind of preserve my surgery.
Sure.
I was so worried about them moving or shifting something or something changing. But now as I've kind of morphed through my practice, I'm much more aggressive about motion. I think that has only benefited people.
Yeah.
And you're the same. And I think that's nice about down here is if there's an issue, you can walk over to my clinic.
Yeah.
You come over and say, hey, I'm seeing so-and-so and they're really stiff. I think we should incorporate this. Or what do you think about this? Or can I add this to the plan?
Absolutely.
Can I go ahead and start strengthening because they're ahead of schedule? And I think that's the nice thing we have here. Or heck, we even call each other or text each other and say, hey,
text. Yeah.
What do you think about this?
That's
so,
right.
I mean, I think that's a really nice niche we have down here.
Absolutely.
And also the custom braces, right? I mean, not only are we getting a surgery for that person and making a treatment plan for that person, now we're making them a custom brace to help with their recovery. And I think that's really kind of benefited our patients overall.
Yeah, absolutely. Yeah, for sure. Well, I had a question for you. So,
hot mic, let's go.
Yeah, what challenges you the most as a surgeon?
It's the juggle of the daily grind, to be honest. And it kind of goes back to what I said before. Being a surgeon is pretty easy. Like that job for me, I'm trained to do that.
Yes,
like once I'm in the operating room and the case is going, like that's kind of my happy place. It's the management of the post-operative stuff. When am I going to move this finger? When am I going to move this wrist? When am I going to move this elbow?
Yeah.
Thinking of the person, not just the surgery. Sure. What do they need? How do I get them back to being a police officer, a firefighter? When can I let them start strengthening their just a bicep repair? Like that is the hard part. And then it's the art of medicine, right? It's navigating the clinic. It's navigating those type of issues and foreseen and unforeseen problems.
Yeah.
I think for me in practice, that was the biggest thing that I had to adjust to. And it's the biggest like daily challenge is not so much in the OR, right? That just comes with time and you build up your skill. It's really kind of all the other stuff. As you know, right?
Yeah.
It's easy when someone comes to you and you're laying your hands on them and they're a thumb joint replacement and you're moving them around like that but it's the other things. Hey, I'm really swollen today. Oh, that really hurt me. What do we do? It's troubleshooting. It's kind of that daily grind's the toughest part.
Yeah.
We wear a lot of hats, like, and like I said, some days I'm a psychologist. Like today, I feel like this office today, I was like a teacher. I was just like drawing on all these things and teaching. I was teaching everybody. And today was teaching day.
Yeah.
It's just kind of every clinic is different, but that's what's exciting about it. That's why I like it.
Yeah. Yeah. Well, and I agree too. The point you were saying too about, dealing with a lot of just different individuals and things going on, not one person is the same, everyone's unique in their own way. And so being able to kind of find just, certain things for certain people that work for them. And a lot of times in clinic too, not all of the things that I do with people are the same.
Sure.
I have to kind of cater it and figure out, what exactly is this person going to respond to well and how can I really cater this towards their occupation or just what they do, in their free time. So it's a little bit of a juggle, but that's what makes it exciting too. Yeah. My job is not the same every single day. I'm going to be seeing something new pretty much on a daily basis. So it keeps things fun.
Yeah, that's what I like about the upper extremity. Yeah, I have my 10 to 15 kind of surgeries that I do all the time, but you definitely get one-offs and different things. Yeah, for sure.
Yeah.
I meant to tell you, I've been listening to this. I meant to tell you about this podcast. It's called the Upper Hand Podcast. It's like it's on Apple or whatever, but it's basically two hand surgeons at Washington University, and they get their like hand therapist on a bunch, but they talk about all kinds of different pathologies, and that's why I was excited to do this. Cool. I listened to the podcast a few times, like get ready for this. I was like, okay, this is what but it's really good.
Yeah.
It's called the Upper Hand. So shout out to the Upper Hand. I'll give them a 5-star review.
Upper Hand. Yeah, that's right.
It's good. They do a good job.
Yeah.
Any other questions for me? Anything that you have? I know you have your little notebook there.
I got my little notebook. Yeah. This was one that I was curious about. So when you're doing tendon injuries and stuff like that, you're going in there and you're seeing a lot of different stuff. Mm-hmm. So I know there's different core strands and kind of your approach to how you're going to repair
Which that's just suture. What kind of suture and how many sutures are we making the tendons kind of come together
sutures?
with. Yeah.
So what is when you're making that decision, how do you go about choosing that? I mean, what's the levels and the severity and that kind of stuff?
Yeah. Tendons are bad. I mean, that's one thing that if someone comes in and, hey, Dr. Rinehart, I got a cut in my palm, and I've cut some of the tendons that help bring the fingers into the palm.
Yeah.
That gives me a knot in my stomach because those are challenging. Not so much surgically technically demanding, but it's the rehab, it's the post-op, it's the expectations, it's all that other stuff that goes into it. Nerves are around there. The nerves can get cut sometimes. And those flexor tendon repairs can be challenging.
Yeah.
So what Landon was talking about is core strands, which really that's a type of a method where we can see how many sutures we can pass through the tendon to give it extra strength.
Yeah.
And really, I just learned something that I did in fellowship. I trained at a pretty high level fellowship, and I just kind of took little tips and tricks from my mentors in certain situations and said, oh, hey, that worked really good in this scenario. But it's case by case.
Yeah.
And you have to look at the quality of the tendon. How old was the tendon cut? How long has it been? Is there nerve damage? And if the nerve's cut too, then that has to kind of play with how you fix the tendon.
Yeah.
But I mean, a lot of it I have to thank to my fellowship mentors for that one, because I use the same suture they use. I was like, I'm never using that suture in practice. And I'm like, I call the OR. I'm like, we better have the suture here today because I mean, and some of it is just a gestalt and what you feel like in the OR, but I mean, those are demanding post-op rehabs, and that's definitely some of the more challenging patients we probably see together is those tendon injuries, because they just kind of come with a slew of issues, no doubt.
Absolutely.
Yeah, that's definitely one of those surgeries that as it walks in my door and I see it, I'm like, ugh. A little bit different than like a thumb arthritis, which we've been talking about, that's really kind of my numero uno. If you said, Kent, what's your favorite surgery any day? I mean, I would say thumb joint replacement any day of the week. It's just predictable. I just know the recipe for it, and people have great success. And really how thumb arthritis presents is as kind of pain kind of around the thumb here, pain with gripping, pulling, twisting, even a little knot, some swelling. And usually the first time I meet someone with thumb arthritis, I mean, try all the easy stuff first, right? I'm not going to do surgery right away. I mean, gels, creams, Voltaren, ICI, Biofreeze, I love that kind of stuff. I use it on myself. Bracing is needed, injections, plus or minus some hand therapy. I think thumb arthritis is one of those pathologies, and you might agree. I think there's some benefit to some prehab or pre-rehab, but once the bones are grinding on each other, sometimes you can almost make people a little bit worse, and they understand that. Some people really want to do every single step and try it, but that's one of those pathologies. I'm a little bit more like, hey, we're going to hit therapy on the back end. Let's try to treat your symptoms, and once our symptom control goes away and you're ready for surgery, that's fine. Kind of the way I do it and kind of what I describe. And, thumb arthritis is kind of, the thumb is grinding on a bone in the wrist. Okay. And that's the trapezium. And I just tell people it's the bad guy. Okay. So bad guy's in the wrist, and it's getting grinded on by the thumb metacarpal or the thumb bone, and eventually just wears so much that the thumb starts to actually dislocate and quite painful. So what you do for surgery, it's an outpatient surgery you do at the surgery center, our brand new surgery center. Shout out to our new surgery center in town. What you do is, and what I do is, make an incision on the back of the thumb here and go. And I just tell people, I'll get my little shovel and I scoop up bad guy and throw him away. You throw him in the trash. And because you don't need him. He's causing all the issues. And then what I do the majority of the time is take a tendon in the forearm. And I kind of joke with people, hey, God gave you this tendon for me to do this surgery. So it's expendable. Take that tendon, roll it up, and kind of replace the bone with that tendon. So the bone is now gliding on a smooth surface instead of a hard surface. And that's just one of those home runs. I mean, I hate to tell people this, because you never want to, you never want to be like, you're going to 100% get better from this. But that's one of those surgeries I get excited about signing up someone, because the satisfaction rate is just so high with that. I do. And as you know, I mean, the big thing with that one is getting your grip strength back. I mean, their pain goes away almost immediately once they're post-surgical pain and swelling. It's just that grip strength. And I tell people 6 months. I don't know if you've seen something in your experience to differ. I mean, sometimes I'll tell them 3 to 6 months, but really I see in my practice, I mean, it takes 6 months to kind of get that grip strength back. But again, I think that's one of those surgeries that I get excited about sending someone over to you. I'm like, okay, I know they're going to do well.
And I mean, too, I think 6 months is totally appropriate. I think it's, first few weeks, it's just getting that general motion down. And I mean, people are moving great. You know, occasionally there's that swelling that's hindering them, or just kind of the scar that feels like it's pulling a little bit. But I mean, the outcomes of that, we follow some really good protocols too, you know, on a weekly basis. Hey,
for sure.
Try this out at home and then come back in and we'll go through some more stuff. Try that out. And from there, it's just a constant progression that we've seen. Until the point where they come back and see you and you're checking up on things. Hey, it's looking good. Let's do some strengthening now.
Yeah.
And that's my favorite part as a therapist. Hey, let's get into the strengthening. Like, let's get that thumb strong so that we can actually get you back to doing what you need to do. And so, I mean, there's a lot of different measures we kind of test and do to look at that and see where somebody's at and kind of where we need to go with that as well. So,
and I definitely think that's one of the newer techniques. I mean, we are pushing motion. That is a surgery that, I mean, when I was taught, it was no moving it for 6 weeks. And I think we're really pushing the envelope here about, hey, at 2 weeks, we're starting to move this thing.
Yeah.
And I think people have really done well with that.
Yeah. Yeah.
You know, I'm excited about doing the podcast in this room specifically because this room kind of holds a place near and dear to my heart, because this is a spot here at TOA Regional that we do wide awake in-office procedures. And I still remember coming on interviewing here with Jeff McPherson and Merrill White and other people being like, I want to do in-office surgeries. And they kind of looked at me like how Clark said, hey, Cousin Eddie, I'd be more shocked if my head was sewn on the carpet than seeing you. You know, they kind of looked at me like I was crazy, but we have really pushed it through, and we were kind of dedicated to get it started. And we had a big team that was committed to start this. And I've been so proud of it. I mean, we do about 200, 250 wide awake surgeries a year. My goal is really to get up to that 300, 350 mark. But it's been really exciting for us. It's so convenient for patient care. People have loved it. They've done awesome with it. You avoid kind of the scuffle of the surgery center, right? I mean, you avoid anesthesia, you avoid IVs, you avoid changing your clothes. You can drive yourself. It's just been awesome.
Yeah.
You know, and kind of the main things we do here, I know you probably don't see a lot of these patients, but from time to time you will. Carpal tunnels, trigger fingers, we'll take out finger cysts. So, I mean, it's kind of nice that we're doing it in here because this room has really been near and dear to my heart. I think we started that September of 23. Is when we started really getting it in motion. Yeah, the late Merrill White was really kind of pushing it through, and we got all the kind of, we have to have all these medicines just in case something happens or whatever. But once we got that approved, it's been awesome. Now we just kind of have a well-oiled machine that we do them on Friday mornings, and for a while we were doing them on Mondays, and then now with the new surgery center, I'm all day Monday at the surgery center, so now we're shifting them to some Wednesday afternoons. But it's just the volume is there because people want it. I know I would.
Yeah.
I mean, I don't want to go to sleep for. Yeah. There's obviously some anxiety involved. I mean, some people just can't do it. They just can't know that I'm doing surgery to them right next to them with wide awake, and they have to go to sleep. But if you can avoid it, always avoid it.
Yeah.
So, it's been kind of an exciting thing here. For us, and I think we're opening up at other locations, but this is really kind of the mothership for this. And I'll hold it. We're the first.
Of course.
So
There you
we
go.
went through all the headaches to get it done everywhere else.
To get it done. Yeah.
So,
Nice.
Yeah.
Yeah.
Anything else there on your?
Yeah. So, I mean, I want to hear just more about for you. So you did your specialty at Indiana Hand. Is that correct?
Yeah.
What made you land on that? And what was that journey like for you?
Yeah. So people, I think a lot of times people just think like, hey, this, he went to high school and then he went to med school and now he's just like a hand surgeon. You know what I mean?
He's just doing his thing.
I'm not as young as I used to look, but they still kind of get like, hey, are you just out of high school? I mean, my kind of background was born and raised in Knoxville, and then went to UT undergrad. Then I went to ETSU for med school, moved away to Nebraska for orthopedic residency. And that's general orthopedic. So you're doing spine surgery, you're doing hips and knees, shoulders, elbows. And then you kind of hone in. I think you just find what's right for you. And you kind of have to decide, hey, do I like bigger surgeries? Do I like smaller, quicker surgeries? Do I like kind of a slower pace, like lower volume type vibe? Or do I want to just see people, do a bunch of things, have a little bit more versatility? I just kind of got drawn to that is seeing a bunch of patients, doing a bunch of surgeries. I really like trauma. I really like taking care of fractures of broken bones, elbow, forearm, hand, wrist, as you've seen.
Yes, a lot of that.
And that just really attracted me to the hand upper extremity world. These are a lot of surgeries that we could do at the surgery center, outpatient, really convenient for people. And I was like, that really drew me to it. And I just kind of like the pace. I like the fast pace of it. So once you kind of hone in on that, I'm gonna go to hand fellowship. So then your 4th year in residency, it's a 5-year program. 4th year in residency, you kind of apply to different places. And one of my mentors, Dr. Dan Firestone, if you're watching, love you, Dan. He was an Indiana hand grad, and he, like, from the day I said I want to do hand, he was like, Indiana's the only place you can go. And it's true, it's a fantastic fellowship. You do the shoulder all the way down, which is what I do in my practice, and it's a year long, and it's busy. And this is where I got the idea of the in-office stuff. I remember my first day kind of walking in, and we had a procedure suite here, and the OR was right next to us, and we just went in between and were doing cases. And I was like, this is so, one, efficient for just operative time. 2, I mean, great for patient care. Coming in, driving yourself for a surgery, I was just like a country bone. I had no idea that people did that, and it was just like, we've been doing this for 20 years like this. I'm like, what? So I just kind of used those newer techniques and brought them here to establish in our practice. But Indiana was really, I interviewed there, and I was like, this is the only place I want to go. But it's competitive. You never know where you're going to land. But I was just thankful enough to go. And we loved Indianapolis. It's a great town and great city. But, shout out to those guys. They gave me all. I mean, I use all the tricks and tips that I learned up there. And it's a 1 year, so it's a kind of a 1 year program.
Okay.
You can kind of split it off, make it to. Some guys do 1 year hand, 1 year shoulder. Some guys add some pediatric work to that. But I was kind of just the standard.
Just general, shoulder to hand.
Yeah, exactly.
Okay. Yeah.
And now I kind of take care of anything and everything from basically the collarbone down to the fingertips.
Yeah.
Are you doing some shoulder stuff every now and then? It's mostly elbow down.
I would say mainly the elbow stuff. If that's like, some of the elbow stuff can trail up to the shoulder a little bit. And so they might have that tight, or even distal radius fracture. Someone's foosh falling on an outstretched hand, that kind of stuff. That shoulder gets a little jostled up. And so I always ask them that too, when they're first coming in, hey, if it was the wrist, how's your elbow doing? How's your shoulder doing? We work our way from proximally to distally. And so I'm really just doing kind of an evaluation of that whole upper extremity and just seeing, what's going on. And occasionally there's those people who's like, my shoulder just really hurts. And I'm like, let's take care of that.
Yeah, for sure.
It is. Sometimes it's that tightness. Sometimes it's just general kind of pain of trying to get it worked out a little bit too. So seen a fair bit of that. So
I think we should do a quick note on wrist fractures just because we do so many down here.
Absolutely.
And what that is, what the distal radius is this part of the wrist here. It's actually the end part of the forearm bone called the radius. But a lot of times we call it distal radius fracture, typically from a fall. Typically older patients have some osteoporosis, sometimes can be high energy things. And really that surgery has really kind of advanced over the past 10, 15 years, and the rehab with it. So from my standpoint, let's just say someone comes in, unfortunately falls, they have a wrist fracture that needs to get fixed on, radiographic parameter, high level athlete, whatever we need. And that's outpatient surgery, go home the same day. I typically do it on a nerve block and just like a little bit of sedation. So they're just kind of taking a nap while you do it. And we've gotten so good with the technology, these can be done pretty quickly and efficiently. And usually that's a cut on the front part of the wrist here, and you fix it. I kind of tell people the ice cream's off the ice cream cone, right? So this is, and it kind of falls off like this. And sometimes I'll draw them the picture. So really what you have to do is you got to get the ice cream back on the ice cream. Got to get back on. And then you buttress it with a plate and screws that suck down onto the bone to hold it there. And the benefit of that is, back in the old days, you can put X-Fix, like little bars and pins sticking out of the skin, or you can put pins in and plaster cast. But the nice thing about the plate is you can start moving that thing right away. And I'm sure we've had patients, we start moving at a week.
Indiana hand too, protocols for that. They say get that thing moving
exactly. ASAP. And that's really been a benefit in technology of taking care of wrist fractures. And I'm aggressive about it because, I just, if it needs to get fixed, I don't like the idea of casting. I want to fix it and then get them moving and really really decrease the amount of recovery and really increase to the whatever outcome they want to get to. And that's what it shows in the literature. This is Canadian literature. So forever, in Canada, because you can't get surgery in Canada. But really the outcomes at 1 year, whether you fix it or not, if you're older than 65 is about the same.
Really?
I mean, read in between lines between that literature, but what we do know is that, I mean, if this is a fracture that radiographically should get fixed and if the patient is able and they're kind of meet all those kind of patient factors of getting it fixed, I mean, they will have a quicker recovery, no doubt. And anecdotally, I think have a better outcome, full disclosure, but that's definitely something that's really evolved over the past 10, 15 years and still has controversy in the hand world. I mean, you'll have people that still will just put them in the cast or put an X-Fix on them or whatever. But I think that's one of the real big advances.
Maybe for some of those people who have been put in casts who maybe came to you, what do you see with that? Is it just a lot of just really stiff?
It's just this. I think it's the stiffness, and I hate stiffness. I mean, I do. I'm a hand surgeon, and I think I just go back to the beginning. I just hate stiffness. I go back to the beginning of practice. I was so slow on rehab and all these. I hate stiffness. I want things to move now. If it's stable and able to move, I want you to move and get back to it. That's good. Once you get your motion back, everything just kind of falls into place as the strength, the pain control, the swelling, all that kind of goes away. I mean, once you get your motion right. I always nervous about casts. Or I'm putting someone in a cast, I always get nervous. Now, some things you just need to put in a cast. Right. And you always worry about stiffness, but that's when I say, okay, looks good. Come to the cast, go see Landon, see what he's got for you. But you maybe cringe about, maybe not. But
no, not at all.
That's definitely the one thing that I worry about. I just saw a wrist fracture today. It was a really bad wrist fracture I fixed. I had to fix the ulna, which is the outside bone, and the radius. And her bone was so osteoporotic, it's so weak that I had to put her in a cast just to let things solidify a little bit. But I did not feel good about it. And the nice thing about here is we have a bone health clinic and a bone health specialist here, Taylor Tapscott, who's one of our nurse practitioners with Dr. Yao. I send a lot of my wrist fractures to her to get evaluated for DEXA scans or labs because I mean, it's really a pathologic fracture. I mean, I think if I pushed you a little bit and you fell, I don't think you're going to break your wrist, but so these are kind of pathologic fractures. And I kind of tell people they're an omen for other things happening. And I think it's worth their time to see Taylor, to get labs, get checked out on, see if they need some oral medications or just some close monitoring. Because God forbid it's their hip, because that changes the whole game. We can get over a wrist fracture, but you break your hip. I mean, now you're bringing mortality into it, right? I mean, you can really have long-term sequela from that. So I think it's been a great thing for us and something I've really utilized. She might get tired of all my referrals, but I'm like, you got to go get it checked out.
Get things like that.
Yeah, because it's important. Because I mean, it is. I mean, it's the first. I tell people it's an omen that something else bad could be going on.
Yeah,
for sure.
What do you say to people? I have people come into who've had a wrist fracture and they're like, I'm afraid that the plates and the screws, those little screws are just going to stick out. What is that? I mean, you said you're kind of buttressing it in and stuff. What does that look like? Yeah,
I mean, and the plate really sits right on the bone nicely. You know, sometimes the way the fracture is or someone's anatomy, it might not always be that way. And you have to kind of be open with the patient. I mean, every patient's different, but the hope is that the plate is right on the bone and they're very thin. They're 2.4 millimeter thin kind of plates, titanium. So there really shouldn't be that prominent, but you do worry. I mean, there are concerns. There's real concerns that have been described. I mean, the plate can be a little bit prominent and you can get some tendon injuries. And if I think a plate's prominent with a person, I mean, I will tell them and say, hey, we'll just got to watch it. And if you can start getting some fingertip pain or something, we just be aggressive and get that plate out. But they worry about that. Hey, is the screw going to be so long? And you kind of have to describe, hey, there's muscles and tendons and there's tissue around it. But for sure, especially small, petite females, I mean, and young females, and that is numero uno, what I get asked for sure. And more often than not, it doesn't cause problems. But I mean, there's been things described that can go have issues. You just got to attack them, right? You can't put your head in the sand. And if they're having a problem with it, you take out the plate as long as they're healed. It's not that big of a deal. From
a therapy side too, with distal radius fractures and that kind of stuff, you were talking about just that general movement and stuff. And what I'm seeing after the surgery is that movement. I mean, once we're immediately doing that, people are getting it back pretty quick. The biggest things too, and I said this before, is just addressing that scar too. Scar management is a really important thing. And I think sometimes it's slept on too, of just really getting that person to start stretching, massaging it, getting it loose. And so there's a few different things in our clinic that we use as well. And that's ultrasound is a great tool. I have this little scar pad I give people. It's Dysum. And it actually is a non-slip material that you can put like in your cabinets and stuff. But basically it kind of helps just to really get some friction on that scar, start massaging it, moving it up and down, side to side, all different directions to get that thing moving. And I've had a really good response with that too. You know, people are using this, they're using their cocoa butter on it with the vitamin E. And so it's got the healing element to it. And that's a big thing too. So yeah, I mean, just working on that. And then too, just keeping it creative too. I think one of the best things they taught us in occupational therapy school is just be creative with what you're doing. And so really to engage patients and stuff and get them to really be active and going with kind of my interventions. You know, I do a lot of different things. And one of my favorite ones that I've recently been doing with wrist fractures as well, I have this Frisbee and there's a little Velcro strap to it. And so I have them hold it like this. And then I put a little ball in there and I'm like, all right, balance this ball. Don't let it move. And then I have them start moving up and down, side to side. I've tried it. It's hard. And I can only imagine with a wrist fracture, it's not fun.
I don't know if I could do that.
Yes. Very well. Yeah. So there's the challenging component to it too. And so I try to figure out, you know, is this person going to respond to this well? But also too, I mean, sometimes therapy can be hard for people. And so that's a great way to just settle their nerves a little bit and kind of break the ice. And so, yeah, just having fun with it, being creative.
And that's great because that leads into like the buy-in factor. I mean, I think, you know, as me, I think you probably see that a lot more than me. You know, they come see me. It's, oh, hey, you know, things are good, Dr. Ryan. But really, it's kind of how do you get the person to buy into the treatment plan? And that's always kind of the juggling act.
Yeah.
You know, you're going to see this laborer and he might be doing really well. I might not see him. I might see him like at his first post-op and then he's just going to go be a laborer, right? And like, you know, how do you just, it's hard, you know? I mean, that's some of the juggling act is to get someone to buy. And I think that's good. Yeah. This is why we love Landon because he does stuff like that. Yeah. I put my head in the sand on scars. No, I do. Scars are one of those things I just forget about, you know, I'll see a carpal tunnel at 2 weeks. And I'm like, yeah, it's a little hard. And I'm like, I really think, you know, I would tell them now to do scar massage almost immediately. If they can tolerate rubbing around the incision, I'm cool with it, even with the stitches in. Yeah. Because I will see that, and it can bother people from time to time. And I wish I did better on education on that. So.
Well, and soft tissue massage too. I mean, like our hand, we've got so many muscles right here in our thumb. This is called our thenar eminence right here. And we've got our hypothenar. And there's just a series of muscles. And again, those tendons, your joints, all of that. So I really just try to relax the hand during our sessions too. And when they're coming in, I've got hot packs sometimes and I'll put heat on it. And home exercise programs and stuff, I'm like, hey, start with some heat. I don't care if it's, you know, dipping your hand in a bowl of water, just warm water, or getting like a heating pad or something like that. If you can relax that hand and just keep it loose, try your exercises after that. And almost 100% of the time, people are like, this heat helps. So, I mean, that's just been a great way to just get people moving and get them started. So it's just trying to relax that hand and make it worthwhile. So,
okay, I'm going to talk to you about one pathology that might be your most dreaded or favorite to take care of. It's definitely something that I try to get in therapy and never operate on. I operate on it from time to time. Don't say I love to do it. Yeah. But I want to talk about the dreaded tennis elbow. And what tennis elbow is quickly is it's a tearing and fraying of the forearm muscles that help and attach to the outside of the elbow here. Yeah. And it's small micro tears that kind of cause inflammation, scar, pain. And really it's kind of a catch-22 because the tendon is trying to heal itself back to the bone, but you keep on using it, re-tearing it, and it's just kind of a downstream effect and just kind of the ball rolls down the hill and eventually most of the time people can ignore it, and then when they come see me, they're pretty inflamed. And I try to say, do nothing. You know, gels, creams, sleeve, injections. As I try not to even inject people on the first visit unless it's been 6 months. Right. And then I kick them out of the door and say, go see Landon. Yeah. So what happens with that 47-year-old guy that's had elbow pain for a year? His wife finally makes him come see me. Yeah. I say, don't come see me, go see Landon. Like, what's your kind of approach to this guy? Yeah. So a big thing with that, so people coming in, you know, typically with tennis elbow, even golfer's elbow too, kind of on the other side here, the medial epicondyle. Second most dreaded tendonitis of the elbow. Yeah. I think too, lateral epicondyle, that's kind of trending towards the pickleball elbow as well. Yeah, for sure. Oh, yeah. That's my, it's a really common one. I don't see it in tennis players. I see it only in pickleball players. Pickleball players, yeah. Well, someone coming in, you know, I typically ask them,
what are you doing? What is it that elicits this pain? What's causing that response? And then 2, it's really just feeling the forearm and kind of seeing how inflamed are we. And so, after asking them a few questions, I get a lot of people who, they type a lot for work, or they're using that mouse. They're sitting at a desk 8 hours a day. Or it's those people who are just really avid gym goers who are just lifting weights. They're doing their bicep curls all day long and
that's all they do.
Yeah, all they do.
Well, I'm jealous. Yeah. I mean, I don't do any bicep curls, but I mean, that's like what they do.
Yes, that's what they do. But really, and then just like a lot of gripping and stuff too. A lot of my mechanics are heavy machinery operators who are doing that on a daily basis. They're constantly just working their arms and moving them. And so I figure out occupation, I figure out what's your pain level, and then how severe is it, and 2, just kind of feeling around. And for the most part, once I'm feeling it and I find that spot, that's when they kind of pull away and they're like, ooh, that hurts. Mm-hmm. And so that's just a good telltale sign of kind of how bad is it. And 2, I always ask them too, what are you doing at home to help relieve some of that pain? Mm-hmm. And so, like you said, the creams, the gels, heat, ice, that kind of stuff. But my approach to it, really education on the front end. I go through body mechanics training, hey, instead of picking stuff up overhanded or picking up really heavy things and stuff like that, just modify your body positioning and your grip. And that has helped a lot, especially for my people who use mouses and stuff. I showed them this ergonomic mouse that keeps the hand in a neutral position, and that's eliminated some of their pain just by the clicking and stuff. And other than that too, it's really just, front end body mechanics, being able to teach them to rest. Some people don't want to rest. Mm-hmm. They're really motivated. They kind of want to get rid of it. And so just, hey, pause all the activities you're doing, try these things. And so some of the things is just upper extremity stretching. So stretching your flexors and extensors. So top of your arm, bottom of your arm. A lot of times people are just real tight up in here. So it's doing that, stretching. It's teaching them nerve glides and wrist glides, being able to kind of move their wrist. And nerve glides, what those are, it's a pretty cool thing. You can stretch your nerve. They also call it nerve flossing. And so it's a good way to just kind of move that nerve. And those nerves can be impacted by some of that pain too. And so I'm really trying to just get everything moving and get it relaxed as much as I can. And so that's a big thing. And ice is a really big component too. If it's really hot and red and irritated, I'm like, stick to the ice more often than the heat, because it's just going to irritate it. And so I always combo up the ice with maybe like a compression sleeve, like a copper fit, or I even use KT tape on it as well. And that helps to kind of just relieve some of the pressure on the tendon and help to just relieve some of the pain that's going on. So there's a lot you can do with it. But early on, it's just trying to manage that pain and that inflammation first off. And then if that starts to trend in the right direction and we're getting rid of some of that, then it's, hey, let's start to introduce more kind of grip, pinch strength, that kind of stuff, and get you back to doing what you want to do or what you need to do. So I blow it off a little bit, but it's a tough pathology, and I kind of do the same thing. I mean, I preach patient. The first visit is preaching patients, right? Mm-hmm. We get an X-ray, make sure things are going okay. We make sure it is actually tennis elbow or lateral epicondylitis. Yes. Yeah.
And then it's just preaching patients. 90% of the time, it's going to get better in 6 months. 6 months is a long time.
It is a long time.
So, you have to have your tips and tricks and do certain different things. And I tell people, very rarely do you have to operate on.
Yeah.
Anecdotally, and you've probably seen the people that do have to require that surgery. And really that surgery, all you do is you just kind of release the tendon and kind of clean up the bone a little bit and reattach the tendon back to the bone.
Yeah.
I mean, those people are so far gone. They've had issues for so long. They almost all do well. No. It almost makes me think, should I operate on this more? But the answer is no. Do not operate on it more.
Yeah.
And you can. And one of my partners scopes the elbow and kind of releases it that way. I've had pretty good results with just making a small little incision on the outside of the elbow and releasing it. But you really try to. That's one of those pathologies. Avoid surgery at all costs.
Yeah. Yeah. And that's an area too in the therapy world that people are still trying to figure out, okay, exactly what should we do for this?
Yeah.
How do we approach this? Because like you said, it can be really different for different people and based on what they do and the severity of it too. So some new things people are trying now is dry needling. That's one thing. There's blood flow restriction therapy. And what blood flow restriction is pretty much, they're taking a blood pressure cuff and you're getting a bunch of measurements. You're kind of dialing in, okay, what's the perfect range for this person? And so what you do, you put this blood pressure cuff on somebody and then you just have them do a bunch of exercises. And what it's doing is over time, it's kind of increasing the oxygen in the blood flow to that specific area of the elbow. And what they're seeing is that people who are doing that and they're making a constant just repetitiveness of it, it's starting to kind of take away those symptoms at a faster rate. And of course you add to that like the ice and a bunch of other things, but that's something that's kind of coming out and there's a little bit more research on it, but still it's one of those things that's just kind of hard sometimes. So yeah,
it's challenging. Well, they're telling us we're taking too long. So we're going to have to wrap it up here in a second, but I'm going to end on one note. And I'm interested in this. I have a few in my mind I think you might go with. I don't know. You might shock me though. What's kind of one case? How long have you been here? It's been a year. Yeah, awesome.
I'm here last June.
So what's one case over kind of the last year that we've collaborated with? Really challenging case that I've kind of sent to you and really started maybe not awesome.
Yes.
And then we kind of had to patch it, whatever kind of plan together, and then got that person to the finish line. What's like one specific thing that you can think of? There's probably a few, but
I'm trying to read your mind a little bit because I think I know who you're talking about. So one individual, this woman, she was walking her dog.
Oh, yeah.
And her dog was on the leash.
Worst elbow fracture I've ever seen.
Yes.
If she's watching this, you know who you are.
And coming from a surgeon, that's a big statement. So he's seen a lot too. So yeah, we talked about that initially. He's like, hey, I got someone who's come to you, just a heads up. And so we talked about that. I kind of had my game plan.
I don't do that enough. I feel like because I'm kind of like, hey, we're good here. But there's those times that if you see the phone, I'm like, hey, this is coming your way.
Yes. So I appreciated the heads up. But yeah, so I mean, just, coming into me, she just had a lot of pain. There's a lot of discomfort. She had her hinge elbow brace. And I just, as a therapist, I'm evaluating a lot of different things. And for her, she's still working. She's got a family, that kind of stuff. So
she's an MOM, man. She's an MOM.
That's right. Yeah. That's right. That's the biggest job of them all too.
Yeah.
So she, but she, hey, what are your goals? I just want to get my elbow to move again. I really just want to get back to doing what I can, the best I can. And so for her, we just, we started moving early on, started doing a lot of modalities. So that's that ultrasound again, that's the heat, the ice, things like that, just to really kind of ease the pain, but also just to help the process, because therapy is a process. And so, that was a really big challenge, but
that was
coming
a win
out
for
of
us,
that,
though.
yes. I mean,
that was a win for
the
for
surgery that you did. Like it worked. She's back to functionally working. And
better than lucky than good on that one.
Yes,
better lucky than good.
Yes,
great patient.
Yeah, absolutely.
I hope she's watching.
Yeah,
that was a win. That was one of those. When I saw that X-ray again, I like trauma. I like fixing bones.
Yeah.
Very rarely do I look at an X-ray and I'm just. I just know what that next part of my life is entailed, so that big win for us, no doubt. I agree. I knew that was my numero uno. That's what I thought you were going to talk about. Okay. I got one more PSA before we close up. This is about dog. This is her dog walking.
Yeah.
I've seen 5 cases this week of dog walkers. You're about to see some of these people.
Man.
Wrapping the leash around the finger with a big dog. Bad idea. Mm-hmm. I've had too many big dogs pulling and bad injuries. Mm-hmm. Okay. Also not paying attention. Then the dog pulls and they fall and they shatter their elbow or they break their wrist.
Watch those curves.
I've seen it. It's only Wednesday.
Yeah.
Be careful walking your dog, people. And thank you for watching. I will see you in Alcoa, Fort Sanders, or Sevierville.
Yeah.
It'll be good, man. We'll talk soon. This was fun.
Thank you.
Thank you, buddy.
Yeah.